Hi, I'm Beth Ramsey. I am currently an athletic trainer for Tulsa Bone and Joint in Tulsa, Oklahoma, and provide coverage for the fourth largest high school in Oklahoma. This is my final project for clinical outcome assessment. For my clinical scenario, I chose an injury that I am currently treating. The athlete is a 16-year-old female reporting to morning treatments the morning after a basketball game. She reports that she played the entire game, but in the fourth quarter, she went to set a pick and turned to move, and her right knee felt like it popped. She reports that her right knee moved funny. Athlete says she was able to finish the game, but woke up this morning and her knee was huge. She is in 10th grade, but starts varsity and says they are in the middle of the state tournament. Athlete reports a previous history of right knee hyperextension. She reports this injury does not feel the same as her previous knee injury. Athlete states that it keeps locking and catching, and most of the pain is on the outside of her knee. She also reports that this morning she tried to jog and was unable to jog without a limp. On physical assessment, the athlete has a large amount of swelling and discoloration. A possible joint effusion is noted. Athlete does appear with a slight limp. She has decreased strength in her vastus medialis and vastus lateralis. Her range of motion, active, has decreased knee flexion due to pain and swelling, less than 90 degrees, and difficult going into full extension. Passive range of motion has decreased knee flexion. On palpation, the athlete reports pain with palpation of the anterior lateral joint line. When I moved on to special tests, I found that the athlete had a positive McMurray's and a positive Apley's compression distraction. Anterior drawer, Lockman, and valgus varus stress tests were all negative. From my evaluation, I believe the athlete has a possible right lateral meniscal tear. She has an appointment already scheduled with Dr. Dukes, one of our team surgeons, this afternoon. He has already scheduled an MRI for tomorrow morning. Athlete will work with ATC on basic knee exercises such as straight leg raises, quad sets, and heel slides. Per the doctor's orders, athlete may ride a stationary bike with no resistance for 25 to 30 minutes to help assist with range of motion. She has also been checked out a power play unit to help control signs and symptoms. Athlete's parents have been notified and have discussed the course of action. For my disablement model, I use the International Classification of Functioning model. Using my case study, I found that 3 of the domains are easily identifiable: body function, activity, and participation. With my athletes, some factors that might be identified under body function is the presence of swelling and discoloration, pain over lateral aspect of knee, gait change, and decreased knee flexion. When looking at activities, we can see the athlete is unable to jog but is currently participating in treatment, which includes stationary bike, straight leg raises, quad sets, and heel slides. Under the participation domain, it is noted that the athlete has running limitations, severe performance difficulties, and inability to participate in athletics. However, the athlete is able to perform daily living skills. The 2 domains that were difficult for me to identify are environmental factors and personal factors. As a high school certified athletic trainer, I can see how some of these may get overlooked, but the more I research this in my athletic population, it could be a huge piece to the treatment of our athletes. The athletic population that I treat come from every socioeconomic background. Some of my students do not have access to adequate health care, access to transportation to attend treatments, or parents who are willing to be involved in the process. For my current case study, though, I was able to identify 5 environmental factors, which include access to an ATC, treatments available at the high school, access to transportation, active parents, and the team doctor is a close family friend. Personal factors affecting this patient is previous history of right knee hyperextension. The PRO I selected for my patient is the Western Ontario Meniscal Evaluation Tool. The WOMET, seen on the right-hand side of your screen, is a 16-item index. It represents 3 domains, which include physical symptom domain, which has 9 items, domain of sports, recreation, work, and lifestyle, which has 4 items, and an emotional domain, which has 3. When looking at instrument development, we look at 3 areas: patient population, item generation, and item reduction. For the design of this instrument, they looked at patients who presented with meniscal symptoms such as swelling, catching, and locking, and also patients whom MRI suggested meniscal pathology. Typically, in the item generation phase, they will begin with a review of similar existing instruments. However, no meniscal-specific instruments are available for comparison. During the item generation phase, they used a patient-centered approach in the development of this tool. The items they included were those items identified by the patients to impact them most significantly on their quality of life. Finally, in the item reduction phase, items were screened to remove any medical jargon, double-barreled questions, and items that were duplicated. Also, any items that change could not perceivably be detected were removed. Lastly, the instrument was adjusted to an 8th grade reading level. The WOMET was found to have test-retest reliability. The interclass correlation coefficient for the WOMET is 0.78. If you recall from the articles presented in this class, anything greater than 0.75 is considered reliable. Construct validity was established by determining that the WOMET correlated highly with the MOTD, ACL, QOL, and it also correlated moderately with the Lysome scale, which has recently been validated as a meniscal-specific instrument. The research data on responsiveness indicated that the WOMET was more sensitive to detecting change over time than other measured outcomes. The floor-to-ceiling effect for patients 6 months post-op were acceptable, with the floor effect being 5.7% and the ceiling effect being 1.7%. When looking at the WOMET, I believe this instrument is appropriate for my current case study. The instrument evaluates the patient's response to meniscal injuries. The WOMET is a VAS response scale laid out on a 100 millimeter long line. The WOMET is easy for clinicians to interpret, but we will look at that more here in a moment. The WOMET has a minimal detectable change score of 103.2. I believe this PRO would be accepted by patients. The WOMET is very patient-friendly, easy to complete, minimal time required, and easy to understand. The WOMET is easily accessible by any clinician with access to the internet. You can successfully implement the WOMET into your current setting for almost next to nothing, maybe the cost of paper and pen. The wonderful thing about interpreting the WOMET is that it is not difficult. To interpret it, you measure the distance from left side of the line and calculate the score out of 100. Total the scores for all domains combined, the lowest score possible being a 0 and the highest score possible being 1600. Measuring changes in patient health status. When looking at measuring change in my case study, I have chosen to use two different PROs, the first being the numeric pain rating scale. As athletic trainers, most of us already use this in our daily practices anyways. I will have the athlete rate her pain daily on the scale and document it accordingly. Second, I will have my athlete complete the WOMET bi-weekly. I chose bi-weekly because I did not want to overwhelm the patient or clinicians and believe that every 2 weeks is sufficient. When looking to see if there is a detectable change, I will keep in mind that the MDC is 103.2. That means that when looking at my patient scores, any change less than 103.2 could be an error in the instrument and cannot be classified as significant change. Implementation strategies. I currently work in a large high school. For my current setting, I have chose to implement the PEDS QL 4.0. I chose this PRO because it is geared toward teens age 13 to 18. This would be considered a generic multi-item scale. Implementation of this PRO could be very easy. I would require the athletes to fill out the PRO during pre-participation evaluations or with their preseason paperwork. To make this even easier for the athletes to complete, I could add it to the electronic paperwork they must submit to be able to participate in practice. Finally, I would ask the athletes to complete the form again if they become injured. After that time, I would have them complete it again bi-weekly and after successful completion of their treatment. When looking at barriers for implementation, one of the biggest barriers we see is difficult for patient to complete. I believe this can include other barriers that were also identified. Research identified some barriers that could fall under difficult for patient to complete, which includes completion time too long, the patient reading level, and the patient's general ability to complete. One solution that could assist in this barrier would be to decrease the amount of time it takes to complete the PRO. PRO should take your patient approximately 10 to 15 minutes to complete. A second solution to a PRO being difficult to complete is making the PRO electronic. Research has shown that patients prefer electronic PROs over paper and are more likely to respond to an electronic PRO. When adapting an electronic PRO in your setting, make sure the PRO interface is user-friendly. Patients only have to answer one question per screen, make the font size larger, and adapt the language for your patient population. I would like to thank you for watching my presentation. I look forward to answering any questions you may have. Thank you.